Well, welcome and thank you all for attending this presentation of the Canadian Life Health Insurance Association, commonly referred to as CLHIA. My name is Frances Martin. I am the Executive Director of the Canadian Kinesiology Alliance. It's my pleasure to greet you today. This invitation was sent to you by your Provincial Kinesiology Association, namely New Brunswick Kinesiology Association, CANS, KPI, and NLK. We will be recording the session, so I would like you to make sure that your microphones are muted at any time. If you have questions, either you put them in the chat so that you don't forget, and we will cover them at the end, or even at the end, by raising your hand, we will address them accordingly. We are particularly delighted to have Joan Weir and Shannon DeLenardo just joining us today to explain more about the health benefit and insurance sector, a sector that is very important to kinesiologists and one that the board sees as one of the critical components to bring the value of kinesiologists as human movement and exercise specialists to meet the health and healthcare needs of the people of Atlantic and indeed Canada. As we know, kinesiologists uses movement science as exercise to both prevent, manage injury, disability, and chronic disease, and improve people's performance, health, and overall quality of life. In times of COVID, we all know that becomes very important. Again, this year, the CKA and the OKA, in collaboration with the PKAs, will be participating in CLHIA's annual conference. We are paying attention to promoting science behind the strong relationship with between exercise, physical activity, and mental health. In fact, this year at the conference, there'll be speakers from the University of Windsor joining us, and we will be presenting the science and evidence supporting the important role of kinesiologists and the role that they can play on mental health. Joan Weir is the Director of Health and Disability Policy, having spent 20 and more years in a leader position in insurance companies. Joan works with all levels of government, advocating for health insurers and leading the development of health policies. And we also welcome Shannon DeLenardo. She is the Director of Anti-Fraud and Electronic Claims. In her role, Shannon is responsible to build consensus on concerns important to member companies and for leading industry committees, working groups, and projects related to the mitigation of benefit fraud and electronic claims management. So welcome, Joan and Shannon. The mic is yours.
Great, thank you so much. I'm going to start off. I'm Joan with CLHIA, and I'm going to take us through the first part of the presentation, and then Shannon will go through the second part, and then we'll just open it up for Q&As. Really happy to be here. Thank you for asking us to do this. And also terribly excited to see the presentation that's going to be offered at the conference. It's such an interesting topic. But as we move to the next slide, I will just give a little bit of an overview of what we're going to talk about. I'll start off by talking a little bit about our organization, CLHIA, and what it is we do, which probably isn't much different than a lot of associations out there. I'm going to talk about the insurance industry in terms of data and what data we have and what it shows. And then I'm going to talk a little bit about some of the common questions I get from healthcare practitioners that will mean something to you in terms of the answers and how kinesiology sort of gets on insurance plans and that kind of thing. So I'm going to talk about how benefit plans are developed, the types of benefit plans that are out there, I have some insurance processes I'm going to go through just so you're familiar with some terminology. And then I'll turn this over to Shannon, who will talk about benefit fraud, about trends, and what industry initiatives that are being undertaken. So for the next slide, I'm going to talk about CLHIA. As I mentioned, we're not much different than many other associations out there. We represent insurance companies, but we also have, and this happened maybe 7 or 8 years ago, we have 17 industry associates. And who those are, they're not insurance companies, but they are companies that have a hand in claims processing. So you may be familiar with the name Claims Secure or TELUS Health, or those sorts of organizations are our industry associates. And the next slide, please. And not going to talk a lot about this because I think you may have this, and if you don't, we can make it available. Really, we're there for our member companies. We're there to, influence the regulatory and legislative environment that we operate in. As you can imagine, we're pretty regulated environment. And we're there really for our members and to work with industry to make sure that our programs work together and that public and private work together. And the next one, please. Okay, now I'm going to talk a little bit about health insurance data. So of course, like any larger, I would say, association, we do have a bit of a statistics area. And we typically each year get in data from our member companies on all of the health claims that they've paid. So we know how much dollars went out the door and how many people were covered. And in this case, as you can see, the circle on the right tells us that 90% of people are covered under group plans. And of course, those are employer paid plans. Typically, sometimes they could be unions or trusts as well. But about 10% are individuals who have purchased their health plan. And those may be, people who work in several different jobs and don't have benefits, or they could be seniors who are purchasing their benefits. The people on the left-hand side of the screen is an interesting data piece. And it tells us that 80% of working Canadians, so people who work, and their families are protected by private health insurance. And the part of that's interesting is that a decade ago, it was 76%. So over the last decade, it's gone in the right direction. We'll see if 2020 data keeps up with that. Next slide, please. And as we get into how we pay out health benefits, you can see on the left what we call supplementary health, which is everything from drugs to travel. There are 26, a little bit of an echo there. 26 million Canadians are covered by these benefits. And, going from the left to the right, drugs and dental are always the largest too. And so we do spend a lot of time on drugs and dental. The middle one is where you fall in, paramedical and vision. We call it paramedical. I know that it's not really the right term, and believe it or not, the next version of this, it's going to be different. But it's a fast growing claim volume, claim dollars out the door. It's probably 14 or 15% increase year over year is what we typically see. And why that is, maybe it's the multi-generational workplace. Everybody wants something different. There are a number of possibilities of what that could be about. And I'll just refer you to Sanofi, the pharmaceutical company. Sanofi does a survey of plan sponsors, so employers and plan members every single year. And they pull together some really interesting data. And this is part of their regular data as well. It might be something you might want to just Google and take a look at the most recent version. And then next slide, please. So now I'm going to launch into how benefit plans are developed. And really, employers want these benefit plans because they're there to attract and retain employees. That's basically the major point. And they have a lot to do with driving employee satisfaction. It isn't just the salary, it's the other sorts of benefits, not just the benefits program, but wellness benefits and other things that the employer can bring to the role. And just a reminder that in some, for some employers, there are agreements in the collective agreements, there are requirements. And typically benefits are a negotiated benefit in that sphere. And maybe changes aren't made one year because, they want sick days or something else is negotiated. I would say really the most important point for employers is that it's to support employee health and to reduce absence and injury and to keep that employee productive and active at work. That's the most important point. And when we assess drugs or we look at dental procedures or we look at kinesiology, it's all mostly for that point. And next slide, please. Key players. This is a busy slide. It's but I do want you to know kind of who makes decisions in what area. So if we start with the employer and plan sponsor, they're really looking at cost, product, service needs, as I mentioned, because they know what their employees want. Employers with employees in more than one province look for consistency in plan design from province to province. So that's kind of a key point. So as kinesiology becomes more accepted and potentially regulated in other provinces, this is what employers are looking for. And as mentioned, it's an integral part of total compensation. So that's the employer. Now there's another key piece of it that I'm going to get into on the next slide, but I want to go through the advisor and consultant. They're sort of key in that relationship. I would say that they're put in the middle between the employer and the insurance company. So the employer is asking the advisor consultant for something. That advisor comes on their behalf to the insurer. So unfortunately, there's not always a direct relationship between the insurer and the employer, which can have a sort of a negative effect on plan design or getting plan changes made, getting contractual changes made, that kind of thing. And then I would say the insurance company, so our members, owns the plan risk or shares it with the employer. I'll talk more about that in the next slide. Manages what we call the employer's investment into benefits, and that would be to manage to a slow rate of increase. And Shannon's got a particular role to play in that, and she'll talk a bit about that. Delivering service, and then protecting the benefit plans, and that's again Shannon from fraudulent claims practices. Next slide, please. One thing about this is that coverages can vary. I know I hear a lot that, well, I know this Sun Life plan and they've got coverage for physio, chiro, and kinesiology and athletic therapy. But that's difficult to infer that from knowing just the insurance company. You kind of need to know the employer, and then employers themselves may have multiple plan designs, such as a plan design for the union, one for management, maybe another for transportation staff. So it can differ definitely within the employer themselves. So our main point on this slide is that plan coverage can't be inferred from knowing who the insurer or the employer is, and best to make sure your patient accesses their benefits plan and understands their benefit plan. And types. Now this is where I wanted to get into it a bit further. There are essentially two types of benefit plans. I'll start with the insured, which is on the right-hand side of that first bullet point. And the insured plan is typically for small to medium employers. I'd say under 100 staff members. We are an insured plan because we're 50, I think. And so that means that the risk of getting that big couple of $100,000 drug claim is on the insurance company. They have all of that risk that they need to cover that. On the other side, the administrative services only plan, the insurance company doesn't have the risk. It's the employer that has the risk. And that's why it's larger employers. And so they take the risk that they're going to get that couple of $100,000 drug claim. And why that's important is because where it's ASO, as we call it, that employer has complete ownership of the plan design. Whereas when it's insured, they don't. it's mostly the insurance company. And I'd say in Canada, ASO is about 65% of the business, and the rest is insured. Talk a bit about traditional benefits plans. These are the ones that you know of, where there's a pot of money for drugs, pot for dental, pot for physio, sometimes, pot for chiro. Sometimes physio may be extended to athletic therapy and kinesiology. Sometimes there may be a pot on its own for those healthcare providers such as yourselves. Flexible benefit plans. This is where the employee gets to choose what's in their own plan from a menu that the employer sets. An example of this where you might opt in would be, if your kids are approaching teenage years and you know that some orthodontic care is going to be required, you can opt in for that part of the benefit plan and then opt out when you're no longer required. The benefit of opting in and opting out is if you opt out, you get to choose something else in its place. And then there are healthcare spending accounts. And those are kind of pots of money. About 35% of us have them now attached to the benefits plan that can be used for certain healthcare spending items. And it's usually tied to the Canada Revenue Agency's definition of what's in a medical expense tax credit. That's that. And then voluntary benefits at the end are just benefits that an employee can opt in, pay for them themselves. The employer arranges it, but the employer doesn't pay for it. So it's a way of getting sort of group better pricing without the employer having actually to fund that particular item. And next one, please. And so now I'm going to go over a few insurance processes. I'll talk a bit about assignment of benefits. You probably know that this is when a claim is submitted by the healthcare provider and payment is made directly back to the provider. In our data, drug is almost entirely this way. Dental is about 68%, and it kind of varies from coast to coast. And then it's about 50% for other claims, and that would be where you would come in and logging onto a portal, potentially by TELUS Health or potentially by another provider or Medavie Blue Cross. And then that claim comes through that portal. The portal also has a member submit portal. And so members, even if you give them a paper receipt, they're probably submitting online through their portal. And just a couple of points that I know Shannon is probably going to be talking about, but I ended up putting them on this slide, is that if there is an unpaid amount, like a 20%, it needs to be collected from the plan member. And why don't we go on to the next one there? Next slide. Yeah. I do want to talk a bit about referrals and authorizations because I think plan members have this assumption that when they go to see somebody different, like a physiotherapist, like a kin, that they need a referral from their family doctor. And honestly, insurers have gone a long way over the last 5 years in eliminating that referral. Still, the perception persists. So if your patient thinks they need to go get a referral or an authorization or a prescription, you suggest to them what I've told you, that most of them don't. And so if they really feel strongly about it, call into their insurance company or look at their plan member portal and see if there is a real requirement for it or not. Nurse practitioners, and I know there's lots in Atlantic Canada, referrals are being much more accepted these days as well when one is required. And of course, a referral was to determine medical necessity. That's the original purpose of it, but really doesn't really fit that bill. So that's why it's been mostly eliminated. Receipts. We have a document called Receipts Best Practices. You will find it on the public side of our website, and it really tells you what you need to have on your receipt. And some of the main ones there: be aware of what's being billed when you bill, provide a receipt, and just some major points at the bottom there. Service date versus receipt date, that probably doesn't apply to you. The provider of treatment, the patient, the quantity or the time, I guess, and service are really important pieces. Okay, next one, Shannon. Coordination of benefits occurs when there's more than one payer for any particular claim. Our rules around that are, and these are industry rules, is that the first payer pays what they normally will. When it goes to the second payer, they compare the remainder versus what they would normally pay, then they pay the lesser. And most of the time, it's the full balance being paid. I will say that COB, as we call it, COB, has become much more complicated with, various multiple plans, blended families. Somebody's got a retirement plan, they go back to work. And so we're in the process of updating this particular document. But again, it's available online on the public side of the website. Next one. Aha. So now over to Shannon.
I'll unmute. It's going to make it far more interesting for you guys if you can hear me. Hopefully it'll be interesting. So to echo Joan's sentiments, thanks so much for asking us to speak tonight. Anyone who knows me knows I'll never turn down an opportunity to talk fraud. We've had our introduction, so I'm going to just jump right in. So fraud's seen in the news almost daily, and now with our current economic environment, we're seeing it even more. And what we're seeing is not just more fraud, but more creative ways of committing fraud. While I was getting ready to do the presentation, I was doing some reading. I don't have to go very far. I get these things fed through my email all the time. But I read about an Edmonton woman who's a creator. She has her own business. And she was just absolutely amazed by how few protections exist around e-transfers. So she had accepted a payment from a client for $350 through an e-transfer, and she never received it. So when she went back to her financial institution to talk about it, they said, well, they're not responsible for that. They're not responsible for reimbursing her. She's just going to be out that money. And, she's just one example of a growing number. In fact, the latest stat I saw was, in fact, 1,800 Canadian victims in 2020, with a total dollar amount of close to $3 million were lost out on e-transfers. And this is huge, especially now with the surge in e-transfers during our pandemic. This opportunity is just ripe for fraudsters as people, hunker down, use less cash. There's fewer face-to-face transactions. Another example is Sasktel, which is a telecommunications company in Saskatchewan, and they're seeking legal action against a former employee to recoup $47,000 in alleged fraudulent workers' comp claims. So this employee was receiving full wage loss benefits through compensation. In the meantime, he was working part-time with another employer. And then there was a Quebec man who was believed to have headed a network of fraudsters that would place phone calls to victims in the United States and advise them that they'd won a lottery. And the lottery was in Canada, but before collecting their winnings, they had to, first pay taxes and brokerage fees and custom fees and all that. And the victims would send the money to the fraudster, either by a wire transfer or by mail. And so he was part of this large investigation that was conducted in collaboration with the United States Postal Service, the Department of Homeland Security, and Custom and Border Protection Agency. And then, so last year, investigators arrested 4 suspected accomplices who actually collaborated with the authorities in exchange for a more lenient sentence. So according to the documents, this Quebec man who allegedly defrauded 37 victims, all over the age of 55, of around $1.5 million. So honestly, I could go on and on and on and talk about schemes and stuff from other areas, but I do want to just highlight a little bit about the COVID trend that has been seen in Canada around fraud. So the Canadian Anti-Fraud Centre, between March 6th of 2020 and March 31st of this year, they had 17,005 Canadian reports of fraud, 15,198 Canadian victims of fraud, and $7.25 million lost to fraud. So I did the same update in July, and the number was, 2,770 reports of fraud, 1,700 victims, and $5.5 million. So this increase is most alarming. So, people just need to be hyper vigilant about the frauds that are going on. So, I've given you several examples. It's clear to see that fraud is not specific to one industry or one sector. So unfortunately, and not surprising, benefit fraud is not exempt from the risk of, or benefit plans are not exempt from the risk of fraud and abuse. The one thing that's consistent, though, is no matter what the sector is, it can have far-reaching implications. So throughout my presentation, I want to share with you some interesting facts on fraud and abuse and the impact plans, some of the trends that insurers are seeing as opposed to these trends I just shared with you. And most importantly, what the CLHIA is doing in partnership with our members to fight fraud, and how we can all be a part of the action to prevent benefit fraud from happening. So at the end of the session, I hope that you'll come away with a greater understanding of what benefit fraud is, how you can protect yourselves from being part of benefit fraud, and what the impact of benefit fraud is on the sustainability of benefit plans. But if you leave with nothing else, I do hope you leave with an understanding that this is a very serious issue, and as an industry, we're taking it very seriously. So I know you just heard some stats from Joan, you heard stats from Joan and who we are from Joan, but the one thing that I really want to emphasize around this is at the CLHIA, we are not operational. So when we focus on policy and advocacy, as Joan mentioned, building consensus with our members, but we don't get into the operational details of how our members run their businesses. So I know you're sitting there thinking, oh, I've got all these great questions that I want to ask. You need to remember that we're not into the nitty gritty. I don't investigate fraud. I don't handle the claims or anything like that. So, I would just remind you of that point. Joan talked about the numbers, and so I'm not going to talk about that anymore. I would reinforce what Joan was saying, though, about the rapid increase in the paramedical claims. And I would also encourage you to check out that Sanofi survey. So now I'm going to get to my first slide. You almost probably thought someone was forgetting to turn them for me. So I guess a big question is, what is benefit fraud, or what is benefit abuse, right? So fraud is essentially, it's when a person intentionally submits false information for the purposes of financial gain. So they're submitting a claim for products or services that were never received, for example. Abuse of the plan, which is equally as concerning to our members, is when a plan member is exploiting the plan, or when the plan is being exploited. So plan members are using up their maximum of benefit type, whether or not it's medically necessary, for example. And one of the challenges with this is that a lot of employees don't actually see this as being wrong, because it's their benefit plan. So they have that sense of entitlement to it. But and they have that sense, especially if they're paying part of the premium, because sometimes the employer pays your whole premium, sometimes you're paying part as the employee. So they don't see this as abuse of the plan, and they certainly don't realize what the consequences could be, where they're putting they're at risk through potential job loss, increased premiums, reduced benefits for themselves or for coworkers. So when we're talking about the costs and the sustainability of benefit plans, we need to be not just looking at fraud, but also at abuse and waste. All three should be a concern. So I guess it's important, what we might want to think about is, what does it look like? What does health and dental benefit fraud look like? And some of these are, things that you could watch for or see. So if a patient's using someone else's health or dental benefit card, once they've exceeded their own coverage, as an example, when you might be asked to increase the amount of a claim to cover a portion that's not covered under their benefit plan. So for example, if my benefits only cover me for 80%, my treatment cost is $100, I'm only going to get $80 back. So they say to you, do you mind? Would you bill me for 120? That way I'll pay you the 100 and I'll get my full 100 back, right? Again, claiming for a treatment or service under dependence coverage when they've exceeded their own. And that this could come about in a couple of different ways. And this is something I want you to think about, because I know quite often, as a provider, you're very concerned about your patients and making sure they get the proper treatment and enough treatment. And, they may not be able to or prepared to pay out of their own pocket for the treatment that they need. So they use all of their treatment dollars up, but they know that their husband and their children, for example, aren't going to be taking advantage of that. So they say, is it possible to bill under my husband's name now and still give me the services? Definitely benefit fraud. Don't get caught in it. If a patient is submitting the full claim for service to multiple insurers and receiving, double reimbursement for that, or this is something that I would really encourage you to make sure you're vigilant about, and that is when a clinic potentially continues to use your number, your registration number, to bill after you've left the organization. So one of the questions that I hear a lot is, what is the cost of benefit fraud? Like, how big is this? What are we actually looking at? And unfortunately, there's not a solid answer for this. Fraud is inherently about deception. It's designed to go undetected. So the truth of the matter is, in Canada, we don't have hard numbers. We do know that there's impacts, right? We know that it could there's higher costs for everyone. It could impact the plan sustainability, and it may create a need for plan design changes. But regardless of what the actual cost is, as that hints right there, it's going to have an impact on everyone, not just on the person committing fraud. And I think that I want to emphasize that it is understood that there's only a small percentage of plan members or providers that are committing fraud. For the most part, everybody's behaving exactly as they're supposed to. But if we think about what Joan shared with us about the industry paying $38 billion in health and dental claims, if even 1% of those are fraudulent, that number is massive. Let's talk a little bit about trends. There's lots of trends, and these are trends that our members are seeing and are sharing with us. Okay, so now we're talking about insurance. So if we go back several years, it used to be that our fraud analysts or whatever, they'd be looking for different handwriting or a different color of ink on a claim form, and that's how they would be detecting whether a receipt had been manipulated and potential fraud was being committed. And while I'm sure there may still be some of that type of activity going on, what we know now is that schemes are much more sophisticated. And with today's technology and, people, this is a full-time job for people. So in many cases, the crime is highly organized, but it can happen across the spectrum. So it can be started at the plan member. It can involve several plan members working together. It can involve medical suppliers. It can involve providers. So it's not restricted to one area, one group, one industry. There is so much money at stake here. So, even if we're bang on and we're shutting things down, they're just popping up somewhere else. So, it's big. So as I mentioned, trends and schemes are evolving, and staying ahead of the challenge, staying ahead of the curve is a challenge. So, not all of these examples that I'm going to give would be specific to kinesiology, but, they are real. So one thing that I would encourage you to be very careful around is applying for positions. You may see a job posted on Kijiji, for example, and you're thinking, oh, that's perfect for me. And all they want as part of your application process is like your personal information, right? So tell me who you are, where you live, what's your registration number. You're giving them all the details, everything they need to actually start up and set up billing under your name. Then you find out the job doesn't even exist, but they have absolutely everything they need to start billing under your name. And I wouldn't want to say, it's only new graduates, because it does impact other people as well, because we just think, oh, this is what they need, so I'm going to give it to them. But it would be something that, new grads, younger people into the profession should be very aware of. I also think that you should consider the fact now that many clinics that we're working in are multidisciplinary. So billing's being done at a centralized location. You may not really have a lot of visibility to the claims that are being submitted. So you want to make sure that you're auditing your own claims, that you know what's being billed under your name. Because remember what you're talking about it just a little bit earlier about what it looks like. So maybe the patient's actually gone to your administrator at the front desk and said, okay, I'm out of this type of treatment, massage, but I really want to keep getting massage. So can you bill it under some other person, right? So under a physiotherapist, give me physiotherapy receipts, but I'll keep getting my massage. So you really want to make sure, especially in those multidisciplinary clinics, how your ID is being used and how billing's being done. Another really common, I say common, but one of the things we hear a lot at the association from our members is collusion between the plan member and the provider. And this is the hardest one to detect, right? Because they're working together, so they're going to protect one another. So the situation can take a whole variety of forms and fashions, but at the end of the day, the provider's billing for the service that they provide. They don't actually provide it. Plan member gets the receipt back, they come back, and right behind the clinic where they're supposedly practicing, there's a showroom with designer purses and shoes and that, and the patient goes in and selects from those items, and they purchase things that aren't supposed to be covered under benefit plans. Fake clinics. People set up clinics, they get a hold of your ID, they're billing under your ID, they've got a post office box or an office front. And when investigators go to check it out, there's actually nothing there. It's just an address used for billing purposes. So collusion, provider, selling, yeah, okay, identity theft. I'm really cognizant of time. So I'm just going to say this one more time. I want to reinforce that we know that it's not everybody that's doing this. It's just a small number of providers or patients that are committing benefit fraud, but the risk to plan sustainability is significant. And that's a key reason that as an industry, we really knew we needed to take some collaborative approaches to combating benefit fraud, because while one insurance company can do a certain amount, like I said, they shut it down in one area, it pops up in another. So as an industry, really, we started really focusing on benefit fraud around 2017, 18, when we pulled together the industry and built a strategy around combating fraud from an industry perspective. And we really decided we would take a two-pronged approach, one around industry tools and one around education awareness. And what I really want to talk to you about is the education awareness piece of it, because prevention through education is key. So we embarked on a multi-year campaign to educate at the start Canadian consumers, and over time we've included providers into that as well. And we really, you know, in order to figure out exactly what we needed to do, we as an industry engaged with some third-party providers. So we, a research company, an analytics company, and a communications company, and set to work about trying to create a campaign that would resonate with Canadian consumers. And in order to do that effectively, it was actually focus group tested. So, you know, we heard from Canadian consumers, if you want your message to resonate, it needs to be direct and it needs to be hard hitting. And so that's exactly what we did. We went direct and hard hitting. And that's what the Fraud Equals Fraud campaign is all about for Canadian consumers. Our image is an orange jumpsuit and handcuffs. And our tagline is real crime, real consequences. It was critically important that we were able to get the message out to Canadian consumers that they 75%, about 75% of Canadian consumers thought the only risk to them for committing benefit fraud is they may have to pay back the claim or potentially pay higher premiums. They had no concept that it was a criminal activity, that they could lose their job, they could lose their reputation, they could go to jail for this. So that's why the messaging is such that it is. So in the first year, we developed our creative, we developed a website, the Fraud Equals Fraud campaign, to educate Canadian consumers. We have a 30 and a 15-second video that was produced that shows a person who has worked hard, who has climbed up through their company, has achieved a great position and some status, and they lost it all by committing benefit fraud. And you see them being walked out of their company by security. And we did this, we went, we had to get the message out. So we used Facebook, we used YouTube, we used Google search, we had media coverage for it. So we really honestly made some significant impacts in our first year on this. And this is kind of the landing page that we have. So it's a basic website. It's got the button to report benefit fraud. So we encourage people. There was a lot of feedback in the research phase that people did not know where to report benefit fraud. So that's really easily identifiable there. There was very few people that wanted to actually get involved and report it. So our awareness campaign has actually really increased people's willingness to report fraud. So the website covers things, what is benefit fraud, what are the consequences, what can you do, FAQs is on there as well. In year 2, and our campaigns are 8 weeks and they run in October and November, just for your awareness. In year 2, we said, you know what, this went well. We got to go big or go home. And that's exactly what we did. We had billboards across major GTA centers. We had transit shelter ads. We continued with our Google search and our social media campaigns. We had the programmatic deals, so when you're watching something on YouTube and a little ad comes up and you can skip the ad, or you're forced to watch it before you can watch the show that you were watching, we were on there. We were everywhere, right? We wanted to really make sure that we were getting the message out to Canadian consumers. While this was going on, I think it's really an important reminder that most of our provider communities are also Canadian consumers. So as an association, we were being approached and we were being asked, what about education for us? What about the providers? How do we protect ourselves? How do we protect our patients from becoming involved in this? And so, so we branched out. And in the third year, we said, let's try and engage with the healthcare provider community. Let's get some education started for that group as well. So we added an additional page to our website. I'm just going to go back there so you can see healthcare providers. That page is very different from the orange jumpsuit and handcuffs. This is all about tips, information you need to know to protect your patients and protect your practice. So there is on this page a quiz. There's FAQs, and both those sections of content were informed by things that we were hearing. What are incentives? What's delisting? Can I bill for more than what the patient gets reimbursed for so that they're whole? Can I discount benefits? So or discount my services for them. So those are the types of things that are on that healthcare provider page, full of great information for you. We're not stopping there though. So now we're rolling into year 4. So all of this was even going on during the pandemic. Our members were still working on this education campaign. And now we're still in the pandemic and we're going into year 4, and our efforts are going to continue. So we're still going to be continuing to educate Canadian consumers about what it is, but we want to really be starting to change their behaviors. So don't get involved. Report it if you hear about it, right? And we're going to expand the program for healthcare providers as well. So together with the Extended Healthcare Professional Coalition and our members, we've been working on developing industry one-pagers. So we've got several of those in the works. One of them is a one-pager on the receipt best practices content that Joan was just speaking to, where we have a larger document. One is focused on understanding the insurance landscape, who the key players are, who does what. One is on just general tips to protect your practice, and one is on incentives. And hopefully we'll be able to continue to grow that library of one-pagers over time so that we're hitting other topics that are of interest to the provider community. But what is really key is that it's messaging that as an industry, our members are aligned with and can stand behind. Then this year, the other thing that we're doing is we want to take content from things like those industry one-pagers, like the supplementary healthcare guide, like our webpage, and actually do a series of educational videos. So it would start with an assessment of people's baseline understanding, knowledge of benefit plans. And then there would be a video on, the insurance landscape and another little quiz. And then, a video on incentives and a quiz. So we're really excited about being able to launch that this year, late this year, or early next year. So, I guess knowing that there's only 7 minutes left because Joan spoke way too long, I just want to reinforce that think using health and dental benefit plans, benefits dishonestly is no big deal. Think again, right? Whether it's just a one-time small thing or a larger ongoing scheme, benefit fraud of all kinds is still considered fraud, and it is a real crime with real consequences. So as I mentioned at the start, as an industry, we're taking this very seriously, and we understand that things are not one and done, and that's why we're in year 4 of our education campaign, and we need to continue to work in a partnership to combat fraud. 7 minutes for questions. For Joan.
Thank you very much, ladies. It was very interesting. At this point, we can entertain questions. I see no question in the chat, but I will certainly take them as we go along. Travis, you have a question.
Hi, thanks for that. I think in Atlantic Canada, I don't know if there's much fraud because unfortunately most of us aren't able to bill. And I'm wondering if you have any suggestions on like the first steps we could take to getting our members able to bill for insurance, because that seems to be really the big concern out here.
Well, maybe I'll take a stab at it, and then Shannon, maybe you can jump in, because yes, I realize that. For the previous insurer I worked for was actually Medavie Blue Cross, so I'm fairly familiar with this. So a couple of things. There are insurers like Medavie Blue Cross who have developed their own systems, and it would be important for you to reach out to them to get your provider type on their system to bill electronically. And then as well, you probably would want to reach out to TELUS Health because many of the insurers use their portal to bill through. So those are the two suggestions I would make as important to start billing directly and electronically. Shannon, what do you have to add to that?
So no, thank you for that answer, Joan. That's great. So I guess that was your concern, Travis, that you can do paper bills, right? But you can't bill electronically.
I think other people that could jump in, but I know that most of our members have trouble billing, period. And so we're really trying to get insurance providers out here to reimburse kinesiologists in the first place. Is my understanding.
Oh, so that actually feeds into your thing, Joan, around it not being part of the plan, right?
Yeah, that's a different question. It's true.
Yeah.
And what I would advise in this case, so there are, you would probably need as an association to kind of develop a little bit of a plan. And I would suggest that there are some large employers that you would go to first, maybe, teachers, hospitals, nurses, doctors, all of those groups that you sort of need to make them aware that you exist, and maybe some sort of cost benefit to adding you on as a provider type. And so yes, you're right that there's a number of plans that wouldn't cover at this point in time. But so there's that. And then there's those consultants, advisors that are in between. So the Mercers, there's a number of them. I could probably, France, I think we talked about this actually, me providing a list to you.
Yes, you are to
Yes.
provide me a list. Yes.
Yes, it's off the email because of the conference stuff, but yes, I'll make another note for myself. So they're important to get to as well. And then with the smaller employers, you probably don't need to go to them. You'd want to go to the Medavie Blue Crosses, the Sun Lifes, and speak to them about their standard plans. And that's the word I would use, standard, and ensure they know the cost benefit of adding you on.
Thank you.
Any other questions? All right. Well, at this point, I'd like to thank Joan and Shannon. It was a great presentation, very educative, and I think that it gives us at least a starting point for those that didn't know the entire picture of how things were dealt. And certainly, fraud is something that you don't quite remember or understand until you're faced with it, or you have then identified that you are asked to participate in such a thing. So thank you very much for highlighting that to our professionals. And I would like to thank everyone for participating. This presentation is recorded and will probably be made available in the following days. And I would encourage all PKAs or kinesiologists getting involved with their PKAs to, as it was mentioned, create some kind of action plan to go out there and reach people. The CKA has other material that you could use that are already available should you need to. So my last point is there any last questions? We're good? All right, well, thank you very much, everyone. Good night.
Thank you for having us.
Thank you. Thank you. And feel free to reach out to us.
All right.
Bye now.
Bye-bye.